In 2002, in France, there was the first case done by Dr. Alain Cribier. And in United States, the first case of transfemoral TAVR started in 2005. So in Cleveland Clinic, we did our first case in 2005, May. Our heart team, when we wanted to start the TAVR in United States, we went to Rouen and we went to Vancouver because these are the two places where transfemoral cases were done outside of United States at that time. We studied all the cases, we studied all the complications. We rehearsed that what we will do if we had a complication. And we wanted to have an emergency service available where we can have a bailout situation, whatever the best possible way, because these were all inoperable candidates. So we thought that if we had trouble, we would not be able to operate on them, because if we could operate, we would have operated in the first place. So we had all transcatheter bailouts for these procedures, and also surgical bailouts if necessary. And we had Dr. John Webb from Vancouver come for the first cases, and first 262 patients that we did in Cleveland Clinic, we had only one person die at 30 days. So this was, and we reported that in the medical literature. So we have it published to show that we had several patients that went close to death. So we had fatal complications, or so-called fatal complications, in almost 15 patients, but all of them survived. We had rehearsed not just with the doctors. The main part was that we had to have infrastructure. So all the equipment, all the nurses, all the talents. So cardiac surgery, cardiologists, cardiac anesthesia, imaging, peripheral vascular disease, aortic dissection management, coronary management, but also all the equipment of all these different bailout situations: coronary stents, wires, guides, covered stents, occlusion balloons, going on pump, different ways of going on pump. So we had tandem heart, we had ECMO, and nurses to be able to do this within 5 minutes. So our goal was that if we decide that something needs to be done, it should be done in 5 minutes. Which of the cardiac team, surgery, cardiologist, anesthesia, who will be in charge of that bailout situation? We practiced that, and we practiced with the nurses to say that who will be in charge of the nursing team, so that it is seamless, so it doesn't look like a chaos. So our 8th case was a left main coronary occlusion, and a lot of people were there in our cath lab because it was very early time of TAVR. And we closed the left main coronary artery, and at that time nobody had survived with left main coronary occlusion, and it had happened only in 2 other cases before in the world, and both patients did not survive. So we had a plan that if this happened to us, what we were planning to do. So we put the patient on tandem heart, we punctured the leaflet that was occluding it. That's what we thought was the problem, studying the other cases. And we could revascularize, put a stent in the patient, and patient lived 6 years with normal left ventricular systolic function.